Welcome to sunny Honolulu, Hawaii, where today I'll be talking about the anterior approach cyclodialysis, the 2-minute glaucoma surgery by Kenneth J. Baum, MD of the Hawaii Permanente Medical Group. I've been performing this procedure since 1994 when, out of my fascination at the profound and persistent hypotony occurring in patients with traumatic cyclodialysis clefts, I began to wonder how I could apply this to my glaucoma patients. It made sense that in a traumatic cyclodialysis, the cleft would form from an anterior to posterior direction, and so I expected my procedure to best be done also from an anterior to posterior direction, as opposed to the classic cyclodialysis procedure. I began to do this with a very blunt Kelman irrigating cyclodialysis cannula in order to avoid any tearing of the uvea. I also began with very shallow clefts. However, as I continued to do the procedure and become more confident with the procedure, we began to increase the depth of the cleft and found that we got increasingly greater lowering of the intraocular pressure. At the point at which I was frequently getting intraocular pressures in the range of 10, I realized that this procedure could give as good a reduction of intraocular pressure as a trabeculectomy with mitomycin C with a much simpler procedure. The most recent change has then been a shift to a rounded cyclodialysis spatula, which is significantly sharper than the Kelman instrument and has made the procedure significantly easier. We'll begin now with a series of 8 of the cyclodialysis procedures so you can get an idea on the speed of this procedure. So now we'll walk through a single procedure and point out all the most important points. We begin after the lens has been removed, an intraocular lens placed, and the viscoelastic remains in place. The cyclodialysis spatula is then passed through the wound, across the anterior chamber, into the anterior chamber angle. Now, most importantly, at this point, an upward pressure is placed on the tip of the instrument to maintain constant contact with the sclera. The instrument is then passed with a twisting movement until a pop is felt, and then a 2 to 3 clock-hour sweep at a 2 to 4 millimeter depth is applied. It is essential, again, that a very constant upward pressure of approximately 30 degrees is applied rather than using a parallel to the iris movement so as to protect the uvea and maintain contact with the sclera. When the instrument is removed, a moderate amount of bleeding usually occurs. The anterior chamber is then filled with BSS to elevate the pressure and tamponade the bleeding. This is then left in place for 2 minutes, after which it is removed with the IA as well as any bleeding. It is not unusual at this point for a small amount of shallowing of the anterior chamber to occur. On the first postoperative day, you should expect some degree of hyphema, ranging anywhere from micro to 3 to 4 millimeters of hyphema. The intraocular pressure is usually mildly reduced on the first day, although occasionally it can be elevated. In cases where it's elevated, gonioscopy has revealed that generally there is fibrin within the cleft, and this generally resolves rather quickly. The major drop in intraocular pressure occurs by 1 week. Pred forte should be begun at QID to hourly, depending on the degree of anterior chamber reaction. It's very important to avoid cycloplegics because they have a tendency to promote closure of cyclodialysis clefts. Patients are generally seen at 1 day, 1 week, and 1 month. It is not unusual to see significant xanthochromia of the anterior chamber persisting up to a month depending on the degree of hyphema which occurred early on. If the procedure is going to fail, it usually will do so within 1 to 3 months. In the first 7 years of using this procedure, I restricted its use to those cases that were combined with a cataract surgery and lens implant. Most recently, I've begun to use the procedure in the minor surgery suite using a 0.3 millimeter incision and no viscoelastic. We've also began to utilize the procedure in selected phakic patients who were not good candidates for trabeculectomy, and we've had good results with intraocular pressure. It is too early to determine whether this promotes cataract formation or not. So I hope that you'll begin to experiment with the anterior approach cyclodialysis and ride the wave of the 2-minute glaucoma surgery. Thank you very much.